Welcome, my friends, to the Bob and Brad podcast, produced by Bob and Brad, the two most famous physical therapists on the internet. I am Bob, and my guest today is Dr. Dane Hansen. He's of Summit Orthopedics. He's a orthopedic surgeon, and he does knee and hip replacements, and we'll get into it. Welcome to the show, Dr. Hansen. All right, Dr. Hansen, thank you so much for joining us today.
You're welcome. Thank you for having me. It's a pleasure.
Well, as we were talking about, we got a lot of questions, and I hope we can just dive into it.
That sounds perfect.
Okay.
Go ahead.
What are the indicators that it's time to have a knee replacement?
I'd say the indicators for knee replacement, arthritic symptoms are pain, stiffness. In knees, tend to see a lot more issues with swelling. So you'll see people get chronic swelling or fluid that collects in the knee, which can cause, that feeling of stiffness and tightness.
Sure.
In knees, you can also get a lot of what we call mechanical symptoms. So if you have loose cartilage, or if your arthritis also, you develop a torn meniscus, things like that, you can see these, symptoms where the knee will catch or lock or
Sure.
grab. And those are big indications too. Something else you see in people that have real chronic arthritis is actual deformity. So you'll see their knee bow inward or outward
Sure.
as they wear down the cartilage in their knee. So you start seeing physical changes in the joint.
So obviously you'll get a side that's longer than the other. And how do you account for that when you do the surgery? So,
yeah. So for knee replacement, yes, when you kind of that same idea, when you lose cartilage, your limb technically shortens, right? Because you're
Right.
actually losing surface and it's collapsing. Along with that, your knee bows. And so that bow doesn't necessarily shorten your bones, but it changes the distance to the floor.
Right.
So it makes
Gotcha.
that limb feel shorter. And so knee replacement is a little bit easier to determine length, because we work within your ligament structure, and your ligaments can only stretch so far.
Oh, gotcha.
And so really we're trying our best to only basically remove the same amount of bone and tissue as we replace. And just by doing that and realigning the knee, essentially straightening the knee back out, we can be quite confident that we're getting that knee back to its, kind of its native or normal length.
Sure.
But most patients, if they do have a significant bow to their knee, they'll notice, they'll come in and actually say, I can tell, or I can feel a difference absolutely in the length of my leg, or the position of my knee, or the alignment of it being straighter than they remember it.
Gotcha. Yeah. The problem I see is when you got two knees.
Yeah, you got it.
Yeah. So can we talk about knee injections? So
yeah,
am I right that there's two main categories, corticosteroid and visco supplementation?
Yeah, I think that's the basics. Corticosteroids, it's a steroid type medication, and it's different than the usual steroid you think of, kind of the muscle pumping, muscle building steroid. It's truly an anti-inflammatory. So it's a very
Sure.
heavy duty anti-inflammatory, and that's what it's doing in the knee. Is it's designed to kind of turn off all the reactions that are going on there. So arthritis is when you lose the cartilage in your knee, when you lose all that protection. But a lot of the symptoms you get are related to how your body reacts to that. So the extra fluid that builds up, the pain, that comes with it,
Sure.
Some of those issues are more related to inflammation. And so if you can use a steroid, what it does is it decreases those things. So pain gets better, swelling gets better, and it can give you, that nice relief.
Sure.
It is very temporary, and that's something I think that we see more and more, is that we used to use these as really consistent and constant, year to year kind of treatments, but we're the success rate or the longevity of them, we're starting to kind of hone in on the fact that, this is a very temporary fix. It gives you relief in those really acute problems where you have a lot of severe pain. But it's not fixing anything in the long term.
When you say temporary, what do you mean? Like 2 months, 3 months?
Yeah, I'd say the
Half a year?
average is probably about 3 months. I have seen people, go longer than that. You'll see people that it can get, more than a year out of one injection. Other people, it's even shorter. They get an injection and steroid for some reason doesn't work in their system as well as other people, and they only get a few days of relief. So, it's again one of those things that it's a very safe thing to try, and it can be very successful. So vast majority of the time we are going to at least attempt that before surgery.
Sure.
Because if you happen to be in that category where you do get that significant amount of relief, it's very worthwhile. But
how many of those can you do a year?
So I'd say most of us would kind of hold to about a 3-month window. So
Gotcha.
That usually means, up 3 to 4 a year is the max that most people would consider. That gives the medication enough time to kind of work its way out of the knee, so you're not overloading it.
Gotcha.
It is sort of most of the steroids are a bit of call it a crystallized type medicine. So there's some solid component to it. And if you get too much in there, it can actually start aggravating the knee.
Making things worse.
Making things worse than better. Yep.
So what about the other category?
Yeah. So visco supplementation is essentially, there's multiple different brands of it, but it's a hyaluronic acid gel. And so it's a cartilage-based gel that is designed to be a lubricant. So if you kind of think about an oil change in a car, your fluid in your knee gets very thin as you develop arthritis. And so it doesn't coat surfaces well. It doesn't really function in the way it's designed to function. And so the theory behind these injections is that it puts a thicker substance in the knee that will give you that better lubrication. Gotcha. The interesting thing about them is, as we again have kind of studied the research on them, the success rate of them is much worse than we thought it was. We kind of get these anecdotal situations, and I still see them. We still use them. Right. You have patients that say, I had a gel injection 5 years ago and I haven't had an ounce of pain since. Wow. And so that can happen. But when you look at the big research studies, they essentially say, we can't prove that they're much better than even just, putting some saline in your knee or, kind of a placebo type of effect. Gotcha. So it's still available. It's still indicated. Patients that are looking for them, if people watching might know or hear that it's getting more difficult to get them approved. So insurance companies are starting to be less interested in paying for them because they're expensive, and we're not, we can't prove much utility with them. Gotcha. So they're sometimes requiring, going to physical therapy or doing other treatments before you can even have one. And the Orthopedic Society has even come out and said, we can't really give a strong recommendation that these are useful injections. So it's again, kind of depending on region or the doctor you're seeing, you may hear them kind of say, no, we don't do them, or I don't do them, or I don't think they're worth it. You may have some that would absolutely recommend it, and everywhere in between. But my use on them, or my thought on the idea is, if you're dealing with extremely young patients that you're trying to avoid joint replacement surgery on, very elderly patients or very sick patients that aren't good surgical candidates, or people that just tell you, I want to do everything that's absolutely possible before I consider surgery. I think there's still a place for them.
Yeah, makes sense. So
now there's one other, I was just going to add on quick. There's one other category that's out there. We talk about the term regenerative medicine. And so you're starting to see more, you will start to see more consideration for PRP injections and stem cell injections for arthritis. A lot of times those have been used for tendon treatments, muscular treatments, not true arthritic conditions.
Sure.
They are available. They are not FDA approved, so people have to pay out of pocket for them. And as of right now, we have not shown that you can truly regrow cartilage. So we are not regenerating the joint, but they have been very successful in more long-term pain relief than potentially something like cortisone would be.
I'm glad you brought it up because a lot of people are asking about that one.
Yeah. And it's, again, it's still kind of, I would call it in its infancy a little bit. It is available. Sure. I think we're still trying to hone in on what the real indication for those are in arthritis, as its own subset. So probably more to come there, but those are available. You will hear people talking a lot about them.
So is it likely the FDA will approve it at some point?
It's hard to know.
It's
hard to know. I think we're too early in the research. I think there is good, there are good studies. Like I said, probably even better data than you would see with the gel injections. But I don't think we have enough yet. So,
sure.
I think it's a time will tell kind of thing, but, it has been approved by the FDA for some other conditions, tendonitis treatments and things like that. So I do think that will, be something probably coming down the line.
Sure. So we talked about hip replacements and how they're lasting longer. Is the same true on knee replacements?
I would say yes. The technology in knee replacements is probably advancing a little faster than hip replacement because we're still trying to, hone in on the perfect system, if you will. If you look backwards, research studies coming out in the last few years are showing that 80 to 85% of knee replacements last over 20 years. And those are, knee replacements that were done 20 years ago.
Gotcha.
And so since then, technology has improved. The plastic bearing surfaces have gotten better. We've added much more use of what are called press fit knee replacements.
Yep.
So same kind of conversation about hip replacement where, typically knee replacement is held in place with a glue, which could potentially break down over time. So in patients with good bone structure, younger patients, active patients, you can place parts that have metal components that the bone will actually grow and heal to. So some of these things I think we're hoping will even advance that further. But again, if you're looking for what I'm telling my patients, I'd say, 20 plus, is kind of is the goal for knee replacement.
What's your breakdown between hips and knees? I mean, do you do one more?
I would say the average is more towards knee. I can't tell you exactly. In my practice, it's probably about 60 to 40 knee replacement to hip replacement.
Gotcha.
There are a lot of surgeons that are more comfortable and willing to do knee replacement than hip replacement. So us surgeons that do hip replacement probably have a little bit higher percentage of that, of that population.
Gotcha.
But I'd say it's probably, 60, 40, 70, 30. So knees are much more common to see arthritis with.
And how long have you been doing this?
Good question. I hear that one a lot too. I'm in my 6th year at Summit. So I've been practicing for 6 years.
You look very young. So
yeah, I appreciate that. Thank you.
So again, let's ask this. What common mistakes do you see your patients make after a knee replacement?
So knee replacement, I think, even more so than hips, the big mistake, there's, I guess, kind of two ends of it. One is not doing enough. So, moving very slowly after surgery. Knees are much more difficult to rehab. So when it comes to regaining range of motion,
Gotcha, yes.
Regaining function, it's a lot harder process, and there tends to be more pain involved with knee replacement. So I do see patients that have a tough time overcoming that and just don't do a lot. And the worry there is that they'll develop scar tissue. They'll have difficulty regaining the function and movement. You as a PT know all about trying to get knees to move after surgery. But that can turn into a long-term issue. So if your scar tissue develops too severely, you can't really fix that, without potentially having more surgery or those sort of things. So you've really got that one chance right after surgery to get the knee moving. So that's a big worry. But again, just kind of like I mentioned with hip replacement, the overdo it probably is almost more of an issue with knees. So knees swell a lot. Knees are quite painful. And so again, you see those patients that feel like the right answer to recovering is just getting up on their feet and doing things all day long. Standing, going back to work real quickly, whatever it is. And those patients get a ton of swelling, and they have a lot of more trouble controlling pain. And so my mindset on it is kind of the happy medium, right? When you're doing your physical therapy, it should be very hard. It should hurt. It should be a lot of work, but you should absolutely put multiple chunks through the day to stop, elevate your foot, ice the knee, rest, and give it a chance to calm down, because that, I think, makes a big difference, and keeps you out of those points where you just get so, overly aggravated that you're falling behind.
Yeah, that was my mother-in-law, unfortunately. But do you still do manipulations?
Yeah. Yep. So manipulation is still something we see. What that is essentially, usually around the 3-month mark of after surgery is when we really start worrying that scar tissue is going to develop too thickly or too fully to work through. And so manipulation is as simple as a 5-minute sedation where you're actually put under anesthesia so that me as the surgeon can do a very, very aggressive physical therapy appointment for you. And that's bending the knee, straightening the knee, and breaking down some of those scar tissue barriers that are holding you back from getting that motion. So, we don't do a lot of them, but they can be, in the right patient, they can be extremely, extremely helpful if there's just sort of that, that last little bit of scar or that last band of tissue that just won't quite give way to let them get that motion back.
It really is a race against scar tissue, isn't it, afterwards?
Yeah, in knees, absolutely. Yeah, very much.
So let's talk about swollen legs after knee surgery.
Yeah.
Common?
I would say very common, and probably more common than hips. Same idea, knees just in and of themselves tend to swell more than hips do. So you'll see patients with large effusions, which is, a large collection of fluid in the knee, whether that's just surgical fluid, whether that's inflammatory fluid during the recovery process. But that in and of itself can cause swelling to kind of push, up and down into the thigh, into the calf. But also very much slows down the venous process. And so you see a lot of foot swelling after knee replacement. So you see patients, we use compression socks. We use, the sequential compression devices, they're called, which are the kind of the sporadic squeezing machines, all to try to keep that fluid moving through the foot and ankle.
Gotcha. A little lymphedema massage too.
That too.
Right. All right. Let's talk about patients' BMI, or are they too heavy for a knee replacement? Is that same issue?
Same issue. Yeah. So that falls right into the kind of the same category as hip replacement. Your BMI of 45 is sort of that big tipping point for an increased risk of in complications. And so, knees tend to be a little easier to manage, in patients that are a little bit overweight. The knees tend not to gain a lot of weight, if you will, so the tissues are still typically pretty easy to work with. But if patients have severe lymphedema or if they have excess tissue, that can lead to more room for fluid to collect, more room for potential infections to brew. And then again, the same idea of medically, managing all the other comorbidities that come with that.
Sure.
The diabetics, the sleep apnea patients, heart conditions, things that tend to go hand in hand.
I think I forgot to ask you this one on the hip replacement, but do you consider any of your patients too old or too young for the surgery?
Yeah. So I'll do knee replacement first. So when it comes to knee replacement, there's no formal age. Again, in previous generations, the idea was, the longevity is so low and we don't have the technology to redo these as we need to. So it was big push to wait till you're 65, 70 to even consider it. That's changed really drastically, partly because our implants are so much better, partly because patients are getting arthritis so much younger now, probably because of activity level and sports and injuries and all these things.
Sure.
But also because we have the technology to redo these as we need to, in a very reasonable way. And so on the young side, I think the goal is to wait as long as you can. I wouldn't just rush into this in your 30s if you can avoid it. But we have patients, I've seen patients down into their 20s due to severe injuries or due to things like juvenile rheumatoid arthritis. There's conditions that cause these joints to degenerate at a very young age. And so it can be young. And then on the flip side, elderly, it's very much a conversation about function, health, function, independence, patients that still live alone. I've got patients in their 90s that still live alone, still drive, still fully take care of themselves. And those patients are still reasonable candidates. It's a different conversation. There's some risks with that, obviously, but sure. I would say it's a case-by-case basis, but you'll see, like I said, wide ranges. You'll see research or you'll see stories of kids in their teens getting hip replacements due to dysplasia or due to, birth defects or things like that. So it's the technology is there to handle those things, but it's, the general mindset is do it in the, later part of life if possible.
Right. Makes sense. All right. How about if your knee is still hurting, a year after surgery, what might be going on there?
Yep. With knee replacement, again, the functional use of a knee replacement and the outcome you get when it comes to aches and pains and things like that, a lot have to do with how far the rehab process has gotten. So again, if you have any chronic scar tissue in your knee, that can cause some pain because your range of motion won't be as full as it could be. And so that can restrict you with certain things or hurt if you bend it too far, that sort of thing. But also muscular function. So strength is a big piece of good knee function. The quad muscle, which is in the front of your thigh, is your main muscle for, just kind of day-to-day knee function, if you will, when it comes to getting out of chairs, climbing stairs, squatting, bending, turning, all that. And so strengthening that muscle is a big part of good function in a knee replacement. And if you don't strengthen it well, it actually very much can cause pain because it affects some of the stability in your knee. It affects the way your kneecap functions and tracks as you move. And so, again, that under rehab is a big reason why people have pain. But then again, just like any other surgery, if there is an infection or if there is complications with the implants or the pieces that are in there, those are all other reasons that, you may have some kind of chronic or lingering pain. And those are important to look into.
What about the knee that's clunking or clicking? There's a small percentage, right?
Right. I would say I would say there's probably the majority of knees click in some way or fashion. And the part of that is just the nature of how your knee mechanics work. So, your knee is not like a hip where it's a ball and socket that stays tightly bound to itself the whole time. Knees pivot, they turn. It's not just a perfect straight forward and back joint. And so there's rotation that happens. Your ligaments are elastic, right? So they are supposed to stretch some so that your knee can pivot and bend and move into different positions. And so when that happens, if you have two hard surfaces, metal and plastic, next to each other, as those pivot and twist and turn and stretch, you're going to feel and hear little clicks. So I see that in most patients. Some people don't notice it or don't care.
Sure.
Some people, it really does aggravate them a little bit. And I would say 99% of the time, those clicks and noises are completely normal.
Gotcha.
You do see some patients where, as we're trying to surgically recreate their stability, we underestimate that. And there can be too much movement in the knee.
Gotcha.
So those tend to have more clicking and clunking, but they also tend to have a lot more other symptoms. So swelling, potentially pain, giving way where their knee wants to kind of cave in on them. So there can be a problem there. But
really
like the vast majority of clicking is not an issue.
You can't do anything about it, right? I mean,
no, you really can't. I kind of actually have learned as I've done more of this. You'd think the tighter you can get those ligaments to be, and the more stable it can be, the better. But I think a little bit of clicking in your knees actually probably expected and probably a good thing, because really, if you look at natural knee mechanics, there is stretch and pivot and movement in your knee. And if you want it to, if you're looking for that function, that's something that is actually probably a benefit after your knee replacement.
This next question I actually had too. I mean, can you kneel after knee surgery, after replacement?
So you can. So a knee replacement, we haven't proven that kneeling on your knee replacement damages it or causes any major problems to it. I would say the vast majority of people don't really enjoy kneeling. And the reason is, I think, two things. One is just, you have an implant, and when you do a knee replacement, the majority of knee replacements, you put a new surface on the underside of your kneecap.
Kneecap, right.
And so even though your kneecap is still there and the bone structure is still there, that pressure you put on that implant and into the knee is much different than what your normal knee would do. And so that's uncomfortable for a lot of people. And then secondarily, your incision for your knee replacement is typically right over the kneecap.
Oh, sure.
And that can be sensitive just because it's some scar tissue there. And it also causes some numbness in the knee right around that incision. And so it's a much different experience to kneel afterwards, but I have plenty of patients that do. I think probably the best advice is, if you do need to kneel or want to kneel for different things, if it's working around the house, if it's gardening, if it's how what you do for work, using pads, whether it's a foam pad on the ground, wearing knee pads, I think it'll be much more comfortable that way.
Are you ever worried about the bone being too thin in the patella and you might break it or not?
Yes, that's not common, but you can see patients when they have really severe kneecap arthritis, they can erode a large portion of that bone away. And yes, we do kind of have a minimum thickness that we need to feel comfortable putting that new surface on, because you have to drill small little holes into the bone to hold for pegs, they're called, to hold those into place. And a fractured kneecap is, one of the worst things that can happen after knee replacement, because it can really significantly affect function. They're hard to fix. And so, yeah, I've had a handful. It doesn't happen often, but I've had a handful where you kind of have to choose just to leave what's there alone.
Gotcha.
And it doesn't drastically affect the function, but it's just there are some of those times where people have gone so far down the road and have dealt with it for so long that that bone structure is really damaged.
Sure. Well, we got to ask about showering and driving also after knee replacement.
Yep. So similarly with knee replacement, the vast majority of us use waterproof dressings. So you can shower usually within the first day or two. Those dressings keep the incision clean and dry and allow it to nicely, just kind of seal off that area. You can wrap the knee. The knee is a lot easier to wrap with like a press and seal or a saran wrap to keep it dry than the hip or other joints. And so that's an option too for some patients, but showering's pretty quick in the process.
Gotcha.
And then as driving goes, it's again, kind of based on two scenarios. It's are you taking pain meds or not? You have to be off any strong narcotic medicines to drive. And also, do you have the functional use of that leg, especially if it's your right leg, to operate? And so again, on average, it's kind of a 3 to 6 week process probably to get really comfortable and confident in operating a car.
Gotcha. All right, we're down to the last question of the day. So anything new on the horizon for knee replacements?
So knee replacement, I think probably the two things I mentioned a little bit, the press fit materials. That is becoming a much more mainstream idea of trying to improve longevity that way. And so I think that will become more and more common to see. Secondarily, robotic surgery is continuing to progress. And so in knee replacement, especially, the technology is advancing really quickly. The idea behind it is helping appropriately align the components to appropriately balance the tissues to make sure that the knee's not too loose or too tight, to make sure the alignment, is just right. And a lot of that can be done by the surgeon, but, robotics can give you a little extra help or can maybe help in some more complex cases where patients have significant bone damage or a lot of deformity to their knee. And so again, it's not totally mainstream, but you'll see more and more and more of that as the years go on, I believe.
Very good. Dr. Dane Hansen, Hansen.
You got it.
With Summit Orthopedics. He's in, I don't know how to pronounce this, Vagnus Heights?
Vadnais Heights.
Vadnais Heights and Woodbury. Yep. And it's summitortho.com if you want to find the website. He's got, again, 55 great testimonials, so you can check them out. So thank you again for joining us. I hope we can have you again some of the time, maybe. Get some more of those.
Yeah, questions. This is great. I'm happy to. I think these are awesome situations. I think patients. Really, my goal always is to help educate people, and in a 15-minute visit, it's tough to get through a lot of things. So
yeah, likewise,
having this kind of info out there, I appreciate it, because I think my patients feel more comfortable. They know they have a little bit more education on what's going on, and I think it's great. So I'd be happy to come back.
Well, thanks for taking the time.
Yes, you're welcome.
Yeah.
Thanks so much.